Very good morning to one and all of you. Today we will be taking a class on renal failure. So we'll just do a recap of the previous topic we did, that is the introduction of the kidney. In that we said that there are four morphological components of kidney, that is glomerulus, tubules, interstitium, and the blood vessels. So why we divide and study the diseases according to these paths are because the pathology and the etiology of these components are entirely different, and even though they overlap at times, the end stage is always renal failure. Okay, so if a disease starts with glomerulus, it will affect tubules, interstitium, and blood vessels eventually if it is not treated. But etiology to start with are different for different components. So glomerulus, usually immune mediated pathway, is the one that causes glomerular diseases, that is antigen antibody reactions and autoimmune diseases, etc. Tubules and interstitium are per se affected mostly by infectious agents and toxins, that is heavy metals like lead, cadmium, etc. Blood vessels, as you know, the most common is hypertension and then impaired blood supply due to other reasons. Then we'll just revise about what are the functions of the kidney that I had said. Main function is to filter the blood and excrete the metabolic waste products. Okay. And then maintain the fluid electrolyte balance. That is how much water we take. So how much water should exit from our body. So if you are taking less amount of water will be excreted through urine so that water is conserved in our body. And electrolytes also as such the same. If we have low sodium, then sodium will be absorbed less in the urine so that we can maintain sodium level in our body. So the fluid electrolyte balance is maintained by kidney partly, and then endocrine organ also it is. So it produces erythropoietin. Erythro means RBC related and poietin means formation. So RBC formation, one main hormone which is important is erythropoietin. So in kidney diseases, when functional part of the kidney is lost, erythropoietin also decreases, and in that case you will get anemia. And then renin is also produced as a hormone from kidney, which is important for renin angiotensin aldosterone mechanism. Okay, so when our BP shoots down or we are dehydrated, renin is secreted from the JJ cells, and then that will cause increase in aldosterone and then angiotensin mechanism and vasopressor, and then it will increase the BP. So this is a compensatory mechanism in our body. And then lastly, it also has a function of regulating vitamin D metabolism. That is, for activating vitamin D, you require kidney. So if kidney is not there, vitamin D deficiency will happen for the patient. So now coming to the topic proper, before that you will have to know about two terminologies, that is azotemia and uremia. What is azotemia? Azotemia is a biochemical abnormality when there is elevation of blood urea nitrogen and creatinine levels in the serum. Okay, so biochemical abnormality in which there is elevation of blood urea nitrogen and creatinine levels in the serum. Okay, this is called azotemia, the biochemical abnormality. It is associated with decreased GFR. That is, you know that glomerular filtration rate is the functional component of the kidney is measured by GFR. Okay, so when GFR is reduced, that means kidney is functioning less. So, but to measure GFR, it is little difficult. So, but easier method is to measure blood urea nitrogen and creatinine level. So, azotemia is a better and easier clinical accessible parameter. And there are two, three causes like kidney can be affected by pre-renal causes like there is no proper perfusion to the kidney, or post-renal azotemia, that is post-renally what all are the kidney disease causes can be urinary flow obstruction. So urinary flow obstruction other than or outside the kidney, that is in the ureter or urinary bladder, Post-renally, when there is obstruction by some stones or tumors or stricture, urine will get accumulated and it will start backflowing and getting accumulated in the kidney. And that is how kidney damage can occur. So pre-renal causes are also there and post-renal causes are also there for azotemia, other than the proper renal causes. And then what is uremia? Uremia is azotemia associated with constellation of clinical signs and symptoms. So when there is only biochemical abnormality, we call that azotemia. And when along with the azotemia, if there is clinical signs and symptoms to the patient, then we call it uremia. Now coming to the topic proper, that is renal failure. Renal failure is an event where kidney fails to remove the metabolic waste products. So the function of the kidney is lost when kidney is in failure. That is just common sense. So all there is a systemic effect, that is endocrine effects will be shut down of the kidney. Metabolically also there will be defects and then fluid electrolyte balance is also disturbed. Consequences are the waste that has to be excreted in the kidney start getting accumulated in the kidney, accumulated in the body. Okay, so the urea, creatinine, and uric acid which has to be excreted will accumulate in the body, and as well as the fluid. You know, the water we are drinking is mainly excreted through urine only. So when kidney is failed, urine won't be excreted and fluid will get accumulated in our body. Now, types of renal failure. There are two types of renal failure, mainly acute renal failure and chronic renal failure. You should remember that renal failure is a systemic disorder. Maybe to start with glomerular disease, tubular disease, and vascular diseases are all starts with the kidney. But ultimately, when kidney goes into failure, all the systemic organs are affected ultimately by that. Okay, some or the other way. So renal failure is a final pathway for kidney and urinary tract diseases. So many diseases are if you are not treated like glomerular, tubular disease or even bladder and ureteral diseases and if you are not curing it properly, it can ultimately lead on to renal failure. So two things is types are acute renal failure and chronic renal failure. As the name suggests itself, you know, ki acute is something wherever we use it is for rapid onset and sudden deterioration of the function, and chronic is slow and progressive deterioration of function. Same here also in renal failure. So acute renal failure, by definition, it is rapid onset, quick deterioration of renal function, which is characterized by oliguria or anuria. Oliguria means less amount of urine is excreted. Anuria means completely there is no urine that is coming out of the body. And then later on, the patient will develop uremia. Uremia, I said, the biochemical abnormality of increase in blood urea, nitrogen, and creatinine, along with clinical signs and symptoms. So, what is acute renal failure? I'll repeat, it is a rapid onset, quick deterioration of renal function, which is characterized by oliguria or anuria, and later on, uremia development occurs. So, etiology of acute renal failure can be pre-renal causes, intrarenal causes, or post-renal causes. Pre-renal causes, as every other organ, vascular disease is the main. That is, proper blood supply is not there. If you are not eating food, you cannot work. The same way, kidney also is not getting the blood supply, it won't work. So proper vascular problems like hypertension and all can affect, otherwise hypovolemic shock or any cardiac diseases, that is why heart is not pumping proper blood, that also will affect the kidney. Okay, so those are vascular or pre-renal causes of acute renal failure. Intrarenal structures in the kidney itself, that is glomerular diseases, acute tubular necrosis, etc. And post-renal causes, as I said, after the kidney, the urine goes, what happens there is ureter or urinary bladder if there is any obstruction. Distal to collecting, that means outside the kidney. If there is any obstruction in the ureter, urethra, bladder, etc., their urine will accumulate and again backflow to the kidney and again will cause problem in the kidney because there is stagnant urine. pelvis will start getting dilated, infection can occur. Ultimately, kidney will go into a failure if the obstruction is not relieved. Okay. So here again, the thing is that if the obstruction is sudden, like stricture or something, or some stones which are obstructing completely, then it can be acute renal failure. But if the obstruction is very slow and slowly progressing, then it will cause chronic renal failure. So it depends upon how much the cause is making the renal failure fast or not. So if it is fast, then it will be classified under acute, and if it is slowly and progressive and irreversible, it will go under chronic renal failure. Now, for academical purposes, you should know that clinical patterns of acute renal failure are there. This you can study in Harsh Mohan in detail if you want. There is syndrome of acute nephritis, which I'll be discussing now after some time. That is nephritic syndrome itself, which is seen mostly with streptococcal glomerulonephritis and rapidly progressive glomerulonephritis. Then there is syndrome accompanying tubular pathology, which you will be discussing in along with tubular pathology, which I'll be teaching, like oliguric stage, diuretic stage, and recovery stage, etc. Pre-renal syndrome, as I said, because vascular supply is cut off, the kidney is not functioning properly. When kidney is not functioning, patient will have oliguria or anuria, and because fluid is not going out, fluid will get accumulated in the body, and then patient will start showing edema. Now we will go into chronic renal failure. Chronic renal failure, as I said, it is slow and progressive damage of the renal parenchyma, which can ultimately lead to death also if not treated. It is progressive and it is irreversible also. It is irreversible decline in renal function, and the causes can be glomerular or tubulointerstitial pathologies usually. So, chronic renal failure is slow, progressive, irreversible deterioration of renal function in which there is destruction of renal parenchyma, which can ultimately lead to death. There are two types of etiologies, that is glomerular and tubulointerstitial pathologies. Once more, it is progressive, slow, irreversible deterioration of renal function along with the destruction of the renal parenchyma. And then etiology is divided into glomerular and tubulointerstitial pathologies. Glomerular diseases that cause chronic renal failure can be two types, that is primary of the renal component, and systemic is that systemic autoimmune disorders that can affect the glomerulus. I said glomerular are mostly immune mediated, that is antigen antibody reaction. So what happens after antigen antibody reaction happens, complement comes, and then inflammation occurs. So inflammation of the kidney is called nephritis, and inflammation of glomerulus of the kidney is called glomerulonephritis. So just remember two things, that is membranous glomerulonephritis and membranoproliferative glomerulonephritis. In systemic, you have to remember mainly two things, that is SLE and diabetic mellitus. The diabetes mellitus, you'll be thinking it is not mainly autoimmune, but you should remember that type 1 diabetes mellitus is autoimmune, that is antibody to the insulin in pancreatic beta islets that is causing diabetes. So these are the causes in the glomerular. And then in tubulo-interstitial pathologies, I said tubules and interstitials are usually affected by toxins and infections. Toxin includes high dose drugs like analgesics and heavy metals like lead, and infections are pyelonephritis. And other than that, it can be also due to vascular pathology of the tubules, that is nephrosclerosis, and then obstructive causes like stones, blood clots, tumors, stricture, etc. Because see, imagine tumor or stone or something is present in the ureter or urinary bladder. It will obstruct the pathway of urine. Now urine will get accumulated and kidney will start getting enlarged because renal pelvis will get enlarged and dilated. So you know that urine is coming from nephron to the collecting duct to the renal pelvis. So when there is obstruction, the urine will backflow. to the tube, ureter, to the renal pelvis, and from there through the collecting duct, DCT, Henle's loop, PCT, and glomerulus. So the reverse order of the nephron is going when urine is back flowing. Okay. So when there is an obstructive pathology, tubules are affected first, and then only the glomerulus and other components are affected of the kidney. Now, there are four stages of chronic renal failure, which is very easy to study if you only know the percentage. First stage may decreased renal reserve, that their glomerular filtration rate is reduced by 50%. Reduced by 50% means 50% of the renal tissue is dead or non-functional. Then there is renal insufficiency stage, in which glomerular filtration rate is reduced to 75%. That is only 25% of the kidney is functional. Third stage renal failure, where 90% of the functional renal tissue is destroyed, means there is only 10% of the renal tissue that is functional. That means GFR will be 10% of the normal. End stage kidney disease, in the GFR is reduced by 95%. That means only 5% of the kidney tissue is remaining, or GFR is 5% of the normal. So you have to remember it is reduced by 50%, 75%, 90%, and 95%. So functional tissue of the kidney that is remaining is 50% in first stage, 25% in second, 10% in third, and 5% in the fourth stage. So symptoms are also in the first stage, it's mostly asymptomatic unless the patient is in a stressful condition like infection or trauma, etc. Second may mostly the patient will have polyuria, necturia and all. And in third stage, by that stage, the main symptoms like edema, metabolic disturbances start occurring. And in end stage, the uremic syndrome is mainly seen in the end stage, that is primary and secondary type of uremic syndrome. Uremia, I said it is azotemia with clinical signs and symptoms. Now let's see how primary uremic symptoms and secondary uremic system symptoms manifest. Primary are the first one mainly directly affecting due to the kidney function. So metabolic acidosis, what happens is that you know that mostly the urine of our body is acidic. So when that is why it is acidic, because there is H plus secretion into the urine. So that is why mostly the urine is acidic, that is 6.5 to 8 kind of pH. So, when H plus is not being excreted in the urine, it gets accumulated in our body. So, when H plus accumulates in blood, it is called acidosis. And it is because of the metabolic problem, it is called metabolic acidosis. Patient will have Kussmaul's breathing as medical sign. And then K plus is also actually excreted by the kidney in the DCT, but this is not happening in renal failure. And then K plus will get accumulated in the body and it will cause cardiac arrhythmia, intestinal colic, and diarrhea. So potassium is a one element which mainly affects heart very much. If it is less also, and if it is more also, it is going to affect heart so much. So hyperkalemia should be looked for in patients of renal failure, and cardiac rhythm and everything should be monitored. Others, as you know, ki water and electrolyte imbalances will be there, and uric acid, which is a byproduct of purine metabolism. Okay, so hyperuricemia is caused because uric acid is not excreted, which should be excreted by the kidney. And as you all know, the uric acid can go and get deposited in the joints and it can cause secondary gout. Okay, so secondary gout is caused by chronic renal failure. Secondary uremic manifestations. What are secondary uremic manifestations? As I said, erythropoietin is not there, so the patient can have anemia. Integumentary disturbances. Integumentary means skin related disturbances. May there is uremic frost. That is, now urea is not getting excreted through the urine. So what will happen? The urea which is accumulated in the blood, it starts getting lost through the sweat. So whenever we perspire or sweat, Okay, start sweating. Wherever we sweat, the urea starts coming out as white crystals, and then they precipitate over our skin. So that is what is called uremic frost. Urea just comes out through the sweat glands, and then they start getting crystallized and looking like a uremic frost. Cardiovascular, I said now fluid is not getting excreted through our body. So now those fluid will accumulate in the blood mainly, and it will be hypervolemic condition. And when heart cannot tolerate that much amount of increased fluid, it can go into heart failure. Now, when heart failure happens, which is the other organ which is affected? See, blood is coming from superior vena cava and inferior vena cava to the right atrium. Okay. Then from right atrium, it goes to right ventricle, and from there to the lungs, obviously. So when there is high volume of blood which is flowing to the right heart, it will be fully diverted to the lungs as well. Okay. So to the lungs also there is increased fluid retention, and it will cause pulmonary edema and congestion. This condition is also called uremic pneumonitis. Now, gastrointestinally, due to azotemia, the patient can have mucosal ulcerations because there is no metabolic acidosis, etc. So, the patient can have mucosal ulceration. Skeletally, I said ki there is inadequate vitamin D activation, so the patient will show osteomalacia. And then the calcium, which should be actually reabsorbed by the kidney, is getting excreted now because absorption is not occurring because kidney function is not happening. So it is lost in the urine. So when calcium levels decrease, hyperparathyroidism occurs. That is, parath hormone will increase to maintain the calcium homeostasis. And that is how patient will have osteitis fibrosa. So these two symptoms together we call it as renal osteodystrophy. Okay. So you should also keep this thing in mind. Keep urine when in urine calcium is lost. That is in the starting stages of renal failure when there will be hyperparathyroidism. Because when urine is not going, calcium is not getting absorbed, but calcium won't be getting lost also through the urine, right? But then there won't be much problem. So it is in the starting stage when there is polyuria and all that calcium is lost and the patient can have hyperparathyroidism. So now I'll show some pics. This is how uremic frost looks like. That I said ki urea precipitate through the sweating and then urea will get deposited as crystals. Then this is how osteomalacia patient will have bow legs. So it's not like exact bow legs or knock knees that you see in rickets. It is osteomalacia is obviously a skeletally matured individual. So there will be bending you can see. And then now we have to come into a very, very, very important topic, that is nephritic syndrome and nephrotic syndrome. These are clinical syndromes of renal failure itself. It can be seen in the stage of developing renal failure or after completely developed renal failure. Anyways, these are the symptoms which we categorize. There are many glomerular diseases itself that will show nephritic syndrome and nephrotic syndrome. And these glomerular diseases, if they are not cured properly, they will go ultimately to renal failure. So, what is nephrotic syndrome and what is nephritic syndrome? So, firstly, I will tell about nephritic syndrome. I said filtration membrane is formed by three things. That is, one is podocytes that are formed by the visceral epithelium of the Bowman's capsule. Second is by the capillary basement membrane, and third is by the capillary endothelial cells. So, filtration membrane is formed by podocytes and then capillary basement membrane and the capillary endothelium. And suppose now glomerulus, the most common disease is the antigen antibody reaction, and that affects the glomerular basement membrane. Now, glomerular basement membrane, when antigen antibody reaction occurs, inflammation occurs. So, inflammation is not something which will be very much confined to one place. So, if basement membrane is inflamed, that inflammation will spread on to podocytes also and then capillary endothelium also. So, when podocytes are affected, the filtration slit, which can carry only 70 kilodalton, size of the molecules will start getting bigger. So there will be more and more bigger molecules can come out. So the patient will be having mainly proteinuria because now protein can cross the filtration barrier fastly. Now you know the barrier is caused between capillary basement membrane, that is capillary, and the urinary space. So if that barrier is lost, blood which has to be filtered and come out only as a plasma filtrate now will come fully as blood itself because there is no barrier, only barrier is inflamed and that barrier is lost. Okay, so blood starts coming into the urine. So the patient with nephritic syndrome will be mainly having hematuria. Okay, and this RBCs, when they are lost in the urine, they can form casts also. So there will be RBC casts in the urine. RBC casts means cast is a structure or an aggregate. Okay, so you imagine so many lots of RBCs are coming through the tubules. So in tubules they get together, they will form a shape of the tubules like cylinder shape. So that is called cast. So cylinder shape aggregate of RBCs, because they are coming through the tubules and then they are excreted through the urine as casts. So casts can be anything. It can be RBC, WBC, etc. Not in this case, it will be RBC only. But casts, usually in other diseases, you can see hyaline cast, WBC cast, etc. So whatever casts it is, they are accumulation of some substances in the tubules. Okay, that will be excreted in the shape of the tubular lumen. So as I said, because podocyte is destroyed, proteinuria will be there. Means podocyte is getting destroyed, so proteinuria will be there, but the proteinuria will be less than 3.5 gram. Okay, because more than 3.5 gram, it will go into nephrotic syndrome criteria. Then there is hematuria and RBC cast. Now you imagine if the RBC cast is so much, it can obstruct the urine flow. When there is obstruction of urine flow, the urine that is accumulated can get infected and the patient can have now pus in the urine because now it is infected. Now when the patient is having obstruction of the urine, then the patient starts showing oliguria and the fluid just starts accumulating in the blood, and then it will cause hypertension. And the fluid now from the blood, it will go to the tissues because now proteinuria is also there for the patient. That is, protein is lost, oncotic pressure decreases, and then the fluid will shift into the tissue space, and then the patient will have edema. So I hope you people understood somewhat. So because the glomerular basement membrane is inflamed so much, the inflammation is spread little to podocytes as well as the basement, the capillary endothelium, and then because of the inflammation, the barrier is lost and protein starts coming in the urine, and then capillary is cut off, so blood itself starts coming in the urine. So patient will have hematuria, proteinuria, and because of hematuria, the RBC can form accumulation in the tubules and they will be excreted as RBC casts. If the RBC cast is not excreted, there is so much accumulation that it starts obstructing the tubule itself. Urine won't go out of the kidney. Now, because the urine is accumulated and obstructed there, it can get infected and cause pyuria. And the fluid is now retained in the kidney because now obstruction is there in the pathway because of casts. Then the patient will have oliguria, and then this, because of the fluid accumulation, there is hypertension to the patient, and then the fluid will go to the tissues also because protein decreased and oncotic pressure decreased, so patient will have edema. So most common two diseases that affect nephritic syndrome are rapidly progressive glomerulonephritis and post-streptococcal glomerulonephritis. Others like diffuse proliferative membranoproliferative nephritis and all, you can remember IgA nephropathy or Berger disease. All these are antigen antibody reaction or autoimmune related diseases. So next we have nephrotic syndrome. Nephrotic syndrome is usually insidious onset and then the patient will be having damage to podocyte food processes only. Okay. So the patient will have damage to podocyte food processes only. So what is happening? The filtration barrier which had a 70 kilodalton space will increase to next level. So n number of proteins now starts going through the filtration membrane, and then patient will be having massive proteinuria which is more than 3.5 gram. You should remember that capillary basement membrane and capillary endothelium is still intact here, so blood won't come. But the filtration barrier mein podocytes are fully affected, so the gap is increased, so proteins and fat starts coming through the filtration barrier. So the patient will be having massive proteinuria, and because the protein is lost, the patient will be having low serum albumin. Okay, because protein is lost, fluid is also lost along with the protein because of the osmotic pressure, and that's why patient will have hypotension. And because protein is decreased, again the same oncotic pressure is decreased, the fluid will shift into tissues and patient can have edema. Okay, then risk of thromboembolism and infection. Immunoglobulins are also proteins. So when proteins are lost, immunoglobulin is also lost. So the patient is susceptible to infection. Immunoglobulins are antibodies. If the patient is having less antibodies, patient is susceptible to infection. Next, anticoagulants and antithrombin. Those are also proteins. So they are also lost as in the urine. So the patient can have thromboembolism. Most easy diseases that you have to remember are coded as MAD, okay? Minimal change disease, amyloidosis, and diabetic glomerulonephropathy, okay? So the patient, because of the massive proteinuria, the patient becomes edematous and patient is MAD also. Okay, you can remember it like that. Minimal change disease, amyloidosis, and diabetic glomerulonephropathy, okay? And then patient also has two more symptoms, that is lipidemia, hyperlipidemia and lipiduria. So how does the patient have increased cholesterol or fat, and then how fat is getting excreted through the urine? Excretion, because filtration barrier is lost, fat is increased in the blood, it starts getting excreted in the urine. But how is the fat getting increased in nephrotic syndrome is explained by this diagram. Chylomicrons. Chylomicrons are the proteins that carry intestinal fatty acids, and intestinal the digestion the fat that is present in the food is converted and carried by chylomicrons in the blood to the liver and other parts, okay, to the liver mainly. So there is lipoprotein lipase which is present in the blood that disintegrate chylomicrons and release free fatty acids, which is essentially important for the muscle and our body. Okay, so when lipoprotein lipase is an enzyme, so enzyme is also basically a protein. So when proteins are getting excreted, enzymes are also getting excreted in the urine. So in this way, lipoprotein lipase is excreted so much in the urine that chylomicrons cannot be broken down. So the chylomicron ratio inside the blood will be increased. That means fatty acids are increased. Okay, means ultimately the cholesterol or the lipids is increased. Now chylomicrons are stuck in the blood because the fats are not released there. And then because in overall body the tissue is not getting proper fat or the fatty acids and triglycerides which is required, so the liver also starts producing lipid. Okay, so lipid synthesis increased by the liver also because the tissue is not getting proper body is not detecting the proper fatty acids because it is stuck with the chylomicrons in the blood. So there is hepatic lipid synthesis is increased as well as chylomicrons in the blood is also increased. So this is how there is hyperlipidemia in nephrotic syndrome patients. So you can remember nephrotic and nephritic in this way also, that is nephrotic has O, so podocyte also has O, and the patient will have massive proteinuria. And then nephritic is something related to itis, that is inflammation. So nephritic syndrome is related to inflammation also. You can remember. So these are things which I have already said. It is immune mediated glomerular basement membrane is affected. Patient will have hematuria, oliguria, proteinuria, hypertension. And along with red cell cast, the patient can have dysmorphic RBCs also. Like you see in this picture, these are the RBC casts which you can see in the wet mound of urine which is unstained. That is why you will see it a bit more colorless. Okay, because when so much amount of RBC is there, there is so much of hemoglobin, and then you might see it is red color. But when you put under the microscope, when it is unstained, to recognize individual RBC level hemoglobin is little not that prominent. So you will see as colorless RBCs or molecules in an accumulated way. So this is shape of cylinder like the tubules. That is why it is called casts. Okay, and dysmorphic RBCs are this RBC when they pass through the filtration barrier, which is already destroyed. Through the destroyed, between the destroyed pathway the RBC is going, it can get cut at the ends. Okay, so that is why it is giving a bizarre shape. Okay, so these are called dysmorphic RBCs. Then in nephrotic syndrome, there is heavy proteinuria, podocytes are affected. Patient will be having edema, hypoalbuminemia, and hyperlipidemia and lipiduria. If you want, you can imagine it as hell also. Okay. Lab investigations in renal failure, what you will be doing, you can just remember it by common sense. That is CBC you will do because the patient will be having anemia or not because of renal failure. You have to see. Then RFT, you will be checking obviously to check whether the renal function is how much it has been deteriorated. And then serum albumin to check whether the how much proteinuria is there, and then serum electrolyte to check for the electrolyte balance. Fasting lipid profile to assess the hyperlipidemia in the patient. FBS to check whether diabetic glomerulonephropathy is a cause or not. ABG analysis you will do to check for metabolic acidosis. Urine analysis obviously to check for dysmorphic RBCs, RBC cast, fatty cast, etc. And proteinuria, there will be frothy urine also. You can do other urine chemical tests also to check for protein, sugar, etc. So summarizing, we discussed about azotemia and uremia. That is, azotemia is biochemical abnormality with increased blood urea, nitrogen, and creatinine. Uremia is when azotemia is associated with clinical signs and symptoms. Then we said about acute and chronic renal failure. So renal failure is a systemic disorder or end stage kidney disease, you can say, which is the ultimate final pathway for all the kidney diseases. Acute is when there is rapid onset, sudden deterioration of renal function that is characterized by oliguria or anuria and the patient presents with uremia. Chronic renal failure is when there is slow, progressive, and irreversible deterioration of the renal function occurs, and there will be slow destruction of the renal parenchyma. Okay, causes of acute renal failure, I said pre-renal, renal, and post-renal causes. Pre-renal is mainly vascular obstruction or decreased blood supply. Renal causes are glomerular or tubular, and post-renal causes of acute renal failure are mainly obstruction distal to the collecting duct. Chronic renal failure can be caused due to glomerular causes or tubulointerstitial causes. Glomerular causes are mainly primary and secondary. Primary by membranous or membranoproliferative glomerulonephritis, and secondary is due to SLE and diabetes. And then tubulointerstitial pathology, I said toxins, that is heavy metals and analgesics, infections like pyelonephritis, vascular like nephrosclerosis, and obstruction can be stone, tumor, stricture, etc. And then I said about the main clinical syndromes, that is nephritic syndrome and the nephrotic syndrome. Okay, I said also about the stages of CRF. That is, first stage may GFR reduces to 50%, second stage may it reduces to 75%, reduced by 75%, third stage may it is reduced by 90%, and in fourth stage it is reduced by 95%. Then nephritic syndrome, I said it affects mainly glomerular basement membrane, and inflammation can spread to glomerular endothelium, capillary endothelium, as well as podocytes. The patient will be having acute hematuria, and RBC casts are passed in the urine, and dysmorphic RBCs are there because podocytes is affected. Proteinuria is also there, but it is less than 3.5 gram. Okay, because RBC cast can obstruct urine, can get infected and cause pyuria because fluid is accumulated. Patient will have hypertension, And then fluid is accumulated due to obstruction. Patient can have oliguria, and then the fluid will shift to the tissues because protein is less and oncotic pressure is less, so patient can have edema. Okay, nephritic syndrome is caused mainly by post-streptococcal glomerulonephritis, rapidly progressive glomerulonephritis, IgA nephropathy, etc. And then nephrotic syndrome is caused mainly due to damage of podocytes of the visceral epithelium. So the patient will be having massive proteinuria, which is more than 3.5 gram, and gram, and then the patient will be having decreased albumin because protein is lost so much, so the patient will be having hypoalbuminemia, and then patient will be having hyperlipidemia, I said, because lipoprotein lipase is affected, and then that lipid will start going through the urine, so lipid urine also. And then edema is there, hypotension is there. Okay, hypertension is there in nephritic, but in nephrotic, it is hypotension because protein is so much lost, water is also lost along with that. Okay, patient will go into hypotension, risk of infection because there is increased antibodies or immunoglobulins that are excreted in the urine. And the most common causes of nephrotic syndrome are MAD, that is minimal change disease, amyloidosis, and diabetic glomerulonephropathy. So with this, we come to the end of this presentation. So kindly do like, share, and subscribe my channel, and then comment on your doubts and the topics which you want me to take. So then, bye.